everyone, and welcome to The Balancing Act. I'm Olga Villaverdi.
And I'm Montel Williams. Today, an effective tool to manage diabetes.
Plus, learning about small cell lung cancer and a clinical trial that's showing great promise, Montel.
Great show. I'm telling you, The Balancing Act starts right now.
Did you know that in the past 20 years, the number of American adults diagnosed with diabetes has more than doubled?
Crazy.
Yeah.
And that comes with a cost of more than $400 billion every single year.
So, the good news here, thanks to new advancements in diabetes technology, today's patients have a powerful tool to manage the disease.
It's a tool that is so effective that it puts the power right in the hands of the diabetes patients. Take a look.
For 73-year-old Alan Collins and his wife Janice, life is all about faith and family.
Howdy, my name is Alan Collins. I'm from Fort Worth, Texas, and I'm 73 years old. My wife's name is Janice, and we've been married 41 years, and she takes care of me. She was a school teacher for many years, and she's always said that I was her worst student. Anyhow, I said, well, that's how it is. And I was a conductor, switchman, brakeman for the railroad. I hired out for Santa Fe Railroad when I was 19 years old and retired when I was 60 with 40 full years of service. Me and Janice, we enjoy going out to eat, and I have a Bible study I enjoy going to. She has a Bible study she enjoys going to, and you know, periodically we'll study together, but that or we'll go for a walk if it's pretty outside. She likes to walk outside. Grandkids, family, that, you know, that has a whole lot to do with life and everything else. So, especially the grandbabies, they make our day.
But Alan's family has also experienced its share of challenges.
So I got a strong family history of diabetes going way back. When I found out I had diabetes, I was 45 years old.
Alan has a personal nemesis on his type 2 diabetes journey, and he's well aware of it.
Food, carbs, sweets, you know. Yeah, food, you know, the older you get, you have very few pleasures left in life, and eating is one of them. So you have to take advantage of whatever pleasures you got. So there you go.
Dr. Chris Bajaj has been Alan's endocrinologist for more than 20 years. Their doctor-patient bond is unmistakable.
I know you're glad to see me.
I've known Alan and Janice for almost 20 years now. He's been a wonderful patient. He's a big character, and we've been focused on his diabetes for such a long time now. My goal is to empower my patients, is to let them have control of their health.
I really like him because he's got a good hairdo like I do. So, you know, win-win.
But all kidding aside, Dr. Bajaj and Alan have seen the tragic results when diabetes can't be controlled.
I remember my grandmother, and I remember as a child that she'd have to go next door to the neighbors, and that's when they had those solid big needles. And I remember as a child watching her take them shots, and that kind of traumatized me about diabetes. And I saw how she suffered and dealt with it, and she ended up losing her leg and passing away with it. And then my older brother, he was like, I think 83, and he had suffered with diabetes this whole time, and he ended up losing his leg. And so lots of trouble. I know about diabetes.
Type 1 diabetes is a condition to where the body just is unable to make enough insulin. Type 2 diabetes is a condition where the body's making insulin, but the body becomes resistant to it. The vast majority of my patients did not like pricking their finger. It was painful, it was messy, and some patients didn't want to do it in front of other people or their family. When we see patients who are on a finger stick, they just have limited data. For the patients and themselves, as well as us, we really just don't have enough information to make good, educated decisions.
One of the most revolutionary developments in the care and management of diabetes was the creation of real-time CGM, or continuous glucose monitoring, delivering continuous and real-time glucose data directly to your smartphone or receiver. The most accurate CGM system available today is the Dexcom G7. As Dr. Bajaj explains, this small but mighty device is a true game changer.
The Dexcom G7 is the newest generation of a continuous glucose monitor, or CGM. I've not seen anything in the past that I could give a patient to help monitor to have such impactful changes to their overall health. It is the most accurate and super easy to use as well. The Dexcom G7 is a continuous real-time glucose monitoring system that goes directly to your smart device without any painful finger pricks. It is small, it is easy to use, it gives the patient so much information, they now have control.
Like many older Americans, Alan was a bit reluctant to try this new technology. But after 2 more years of finger sticks, his wife Janice finally convinced him.
You know, the thing about diabetes, you can never just be. You gotta always be aware, where's my blood sugar? Am I high? Am I low? You know? And that was always very troublesome. I'm not a very technology person, you know? And in fact, Janice made me get an iPhone, you know, and I still haven't got it all figured out. Technology, I'm old school, I'm old set in my ways, you know, but long story short, I had an episode in Dr. Bajaj's office where I really had a bad low. And that's what kind of convinced me, and Dr. Bajaj come in there and said, you're getting on Dexcom, period, you know, so.
The G7 delivers continuous and real-time glucose numbers 24/7 to the patient's smartphone or receiver. It also alerts the patient when their glucose level is too high, and up to 20 minutes before it goes too low. The Dexcom G7 is even clinically proven to help lower A1C.
In the past, we would check a hemoglobin A1C, and that would give you a big picture over the past 3 months, but we'd have to wait that long before we'd see any changes. With the Dexcom G7, we can get an estimated A1C in as quick as 2 weeks. We tend to use a lot of different medications to get their blood sugars controlled. One of the more popular medications is a GLP-1. It's a once-a-week injection that helps bring down their glucose. It can also help patients maintain a healthier weight. GLP-1s and Dexcom now complement each other, and I'm surprised to see that the Dexcom G7 was able to lower the hemoglobin A1C without even making any medication changes.
And Dr. Bajaj says that for the first time, Alan is finally in charge of his diabetes.
Using the Dexcom G7, patients are able to see the changes that they make. And ideally, I want patients on less medicine. I've seen it day to day make significant impacts in our patients' lives, improves their blood glucose, it gives them control, and it gives them some confidence in what we're doing as well.
I've known Dr. Chris about 20 years. He's just been a great doctor, and he has really helped me with my diabetes and my struggle about living with it. And he's very patient, very understanding, but he's, you know, he's firm when he needs to be. Janice, through this diabetic struggle, she's really been a rock for me. But where I screwed up is I shared with my wife. So I'll be out mowing the yard, you know, sweating and all this. I think I'm doing a good job, you know, working. All of a sudden, Janice comes running out the door with peanut butter and crackers and says, "Do you realize you're going low?" That's kind of one of the better benefits of all of it, is the fact that it'll tell you, hey, eat something, dummy. Life with the G7 is much better. You know where you stand. And I think every diabetic should have one because, like I say, it's a game changer for diabetes and living with it.
For more information about diabetes management and the G7 continuous glucose monitoring system, go to Dexcom.com.
And of course, you can also get more information by going to our website, thebalancingact.com.
We'll be right back.
Yes.
Small cell lung cancer, or SCLC, is a highly aggressive lung cancer notorious for the tendency to spread quickly and metastasize early.
Yeah, and because of that fact, it's often not diagnosed until the advanced stages, which results in significant challenges in the treatment and management of the disease.
Although some recent advances have been made, the prognosis of SCLC remains dismal, making the need for research and clinical trials for effective treatments more critical than ever.
Small Small cell lung cancer comprises 15% of all lung cancers. Due to how quickly it spreads, approximately 70% of patients present with extensive stage small cell lung cancer disease. Unfortunately, due to the aggressive nature of small cell lung cancer, most patients are seen by an oncologist after the cancer has spread extensively and are suffering from symptoms, the most common including cough and shortness of breath. Patients may also experience coughing up blood, trouble swallowing, and even weight loss. Smoking is a major risk factor for small cell lung cancer. Other notable risk factors of developing small cell lung cancer include exposure to chemicals such as asbestos, exposure to radiation from sources such as radiation therapy in the breast or chest, or radon in the home or workplace. When a patient comes to me with symptoms that are suggestive of lung cancers, I perform a series of tests and procedures to diagnose small cell lung cancer. If the imaging suggests a possible tumor in the lung, the next step is a biopsy. It's important to remember that even though we may have a suspicion for cancer, we cannot tell a patient that they actually have cancer until they have a biopsy-proven result of cancer.
Once the lung cancer is found, it's important to determine whether the cancer is at limited stage or extensive stage. Limited stage cancer, which is potentially curable, is treated with various standard of care modalities such as chemotherapy, radiation, and surgery. Extensive stage cancer is incurable, and chemotherapies are used to improve and prolong survival.
Unfortunately, while most small cell lung cancer patients have an initial response, the majority recur and have resistant disease. When a patient has resistant disease, there are very few treatment options for them at this point. Clinical trials can help fill this void by finding the new and better treatments for small cell lung cancer.
When we come back, the emerging clinical trial landscape designed to meet the unmet needs in small cell lung cancer.
We'll be right back. Until recently, the treatment landscape for small cell lung cancer has had a very limited collection of effective treatments. Currently, there are emerging strategies and recent clinical trial efforts focusing on exploring combination therapies to improve outcomes for small cell lung cancer patients. One such clinical trial through a partnership with Fosun Pharmaceuticals and Henlius is a randomized open-label study of serplulimab plus chemotherapy compared with the standard of care atezolizumab plus chemotherapy in previously untreated patients with extensive stage small cell lung cancer in the United States.
Having benefited from thousands of Chinese patients and based on the promising results so far, the treatment was granted orphan drug designation by the FDA and the European Commission for the treatment of SCLC.
While these advancements in the treatment of small cell lung cancer have moved the needle forward, another significant challenge persists: how to ensure diverse representation within these trials.
It's our job to try to make sure that everybody, regardless of their economic status, their racial background, their gender, has access to quality medical care. So we have to reduce the gap between those who have adequate medical care and those that don't. I don't want patients, due to a lack of insurance, lack of transportation, the color of their skin, their gender, their sexual orientation, to not have access to these clinical trials. Not all people respond to medications the same way. Say, for example, African Americans may not respond to a certain high blood pressure medication compared to the general population. So it's important to include everybody so you can find out exactly if this medication is going to work, and if not, why. So the next step is to tailor a trial that includes everybody with these questions in mind.
Increasing levels of trust and awareness within diverse communities has become a major goal of the ASTRIDE trial.
Unfortunately, throughout our history, certain populations were mistreated. not only by the medical profession, also by clinical researchers. We all know about the untreated syphilis trial in Alabama, and it's a fallout from that. Unfortunately, there's a mistrust in the medical system due to these instances, and unfortunately, that mistrust spans generations where we are now, but we have to break down these barriers to allow patients to get on these clinical trials. The only way we can do that is to regain that trust. It's been proven that if I ask an African-American patient to go on a clinical trial, they're more than likely to say yes because we have the same cultural background, understand historical references, and they understand that I will not do anything to them that I wouldn't do to my own parents. It's important that we ensure that the next generation of clinical trialists and the physicians and scientists look like the general population. The reason ASTRIDE is important is because, they're opening up clinical research sites, not only in academic facilities where a lot of clinical trials are performed, but in community settings where the patients are. But particularly, there's going to be a real emphasis on enrolling patients who are generally underrepresented in clinical trials historically, specifically African Americans and Hispanic. Because we need that data to ensure that this medication is going to work in all populations. That's why I got into medicine. I'm passionate about ensuring that people live longer. But that means everyone, not a small population. Cancer does not discriminate.
This distinctive focus also extends to an emphasis on the exclusive enrollment of Asian American Pacific Islanders. The ASTRIDE trial is not only a model for change in the clinical trial landscape, but it also stands as a beacon of hope for small cell lung cancer patients.
For most patients, they typically will ask, what do you have for me? What type of treatments are there? I am very excited to speak with them about a clinical trial, to teach them about the opportunity that they have to enroll and be part of something bigger than themselves that in the short term may help them, but then may also extend the lives of others. It offers hope for a disease that is typically hopeless. I feel very honored to be able to tell them that they aren't alone.
And for more information on the ASTRIDE clinical trial discussed today, visit smallcelllungcancertrial.com. And as always, you can go up to our website, thebalancingact.com, for more. We'll be back right after this. Thanks so much for joining us today.
Remember to head to our Facebook page, like us on Instagram, follow us on X, and visit thebalancingact.com to enter our latest sweepstakes or giveaway.
Absolutely. Stay safe. Love that family of yours, and we'll see you next time.